This episode is brought to you by my Fertility Awareness Mastery online self-study program. Learn fertility awareness from the comfort of your own home at your own pace for a fraction of the cost. Head over to fertilityfriday.com/mastery for details. That's fertilityfriday.com/mastery. This is the Fertility Friday podcast, episode number 386. Welcome to the Fertility Friday podcast, your source for information about the fertility awareness method and all things fertility. I'm your host, Lisa Hendrickson-Jack. I'm the author of The Fifth Vital Sign and the Fertility Awareness Mastery Charting Journal. I'm a certified fertility awareness educator and holistic reproductive health practitioner with nearly 20 years of experience teaching women to connect to their fifth vital sign through menstrual cycle charting, balancing hormonal health, and optimizing the menstrual cycle without hormones. I'm outspoken about hormonal birth control and its impact on fertility and overall health because you have the right to know how your body works and how artificial hormones disrupt that natural process. I host live coaching programs to help you achieve optimal fertility and health because it's important to have healthy menstrual cycles regardless of whether or not you want to have babies. I'm also a wife and mother of two beautiful boys. I know, I'm a busy girl, but I managed to fit it all in. This podcast is designed to empower you to take full control of your cycles, your fertility, and your overall health. And I'm so excited that you're here with us today. Today, I'm excited to welcome Justine Bold to the show. I feel that today's episode is a great follow-up to last week's episode with Joe Whitaker, in part because Joe was one of Justine's students and he connected us, and that's the reason that we were able to do this interview. But I'll tell you a little bit about Justine. Justine has worked as an academic in the UK at the University of Worcester since 2008. She is now also the program director in the medical school at Cardiff University. She's written articles on infertility. She's appeared in the media. She co-edited a book entitled Integrated Approaches to Infertility, IVF and Recurrent Miscarriages, which was published in 2016. She has published widely in academic journals on gluten and celiac disease, and also on the integrative management of female reproductive health conditions. She's currently working towards her PhD by publication, and she's recently contributed chapters to an upcoming textbook called Gluten-Related Disorders. In addition to Justine's academic history, she's also had a long personal journey to motherhood, starting with a pregnancy loss in her early 30s, and finally became a mom in her 40s. And in today's episode, we really talk about a balance of both of these things. Justine's personal story is incredibly powerful, and really it speaks to me because it's an important reminder of how important it is that as women we are able to learn about our fertility, our cycles. In a perfect world, we would learn these things young, and we would learn how our fertility changes with time so that we can at least do our best to kind of plan for what life may throw at us. And in the second part of our interview, we really get into the topic of gluten and fertility, and how for those who are sensitive to gluten or have a condition like celiac, how it can really impact fertility in a negative way. So there's a ton of incredible information in today's episode. And without further ado, let's go ahead and jump right in. And I'm very excited to be here today with Justine Bold. Welcome to the show.
Thank you very much. I'm really delighted to be here. So thank you for asking me.
Well, I'm thrilled that we were able to connect. We connected through a student of yours, which is really fun, who is also on this podcast. I think I'd like to start because before we jumped into the interview, we were having a very important, I would say, dialogue about fertility. And I feel like that would actually be a really great place to start the podcast. I'd love for you to share a little bit about your personal experience with fertility challenges and how it led you into the work that you're doing now in the academic field.
That's great. Thank you, Lisa. So I had a really long journey to motherhood. I tried to get pregnant in my early 30s, but lost the pregnancies. One of them I lost in the second trimester, actually, and that hit me pretty hard. There were no known reasons identified for losing those pregnancies. I'd kind of had a career in advertising. I wasn't working clinically in nutrition, which is what I do now. At that point, career was quite important to me. I'd sort of climbed the ladder and was working quite long hours. It's quite a dynamic industry. My relationship kind of suffered after those kind of losses, and in the end broke down, and I didn't meet another person and start trying again until I was 37. I had no idea that it may be difficult for me. So in my own life, my mum had got married quite young, when she was 21. She had me soon afterwards. Then she had my brother. She only had 2 kids, so I've only got one brother. But she'd encouraged me a lot in my career and to academically as well in terms of going to university. So there was no pressure really for me to get married and have children. I don't remember anybody even kind of suggesting that I ought to get on with it. So that's not to say that I'm saying that they're to blame, because they're not. I think just culturally at the time, fertility education wasn't done essentially in the UK. So at age 37, I start trying to conceive. I'm timing intercourse, I'm doing ovulation pee sticks and temperature checking and cervical mucus checking, and nothing's happening. And by this point, I've already retrained to be a nutritional therapist, which is what we are in the UK, which means I'm a sort of nutrition practitioner using sort of evidence-based approaches, but using a system called functional medicine, where you look at kind of root causes of conditions. At this point, I start to employ what I know on myself: diet, lifestyle, cutting out drinking. I was eating pretty healthily anyway, but, eating more healthily, taking a lot of supplements. And I kept on trying. And 2 years later, I go to the doctor, age 39, and say, I've been trying really hard to have a baby, and nothing's happening. So at that point, we were told that I was too old to have investigations paid for on the NHS in the UK. And I paid for some privately, actually, which when I was 41, I was diagnosed with. It took quite a long time to go through the blood tests and preliminary tests. And I had my AMH done and all this kind of stuff and all the STD screens. And then I got scheduled for laparoscopy. And I think when I was just 41, they told me I had endometriosis, which came as a real shock. I had been back and forth to the doctors multiple times, period pain, but also I'd been on the pill for a long time. So I must have been on the pill up to my early 30s, then off the pill. And then I didn't go back on it in the middle bit, because I would have been quite happy after the losses if I'd actually got pregnant. I guess having had the pill, that probably masked, the worst of my symptoms, perhaps with the endometriosis. So it was a bit of a shock to be diagnosed with that. What happened then is more losses after that. And age 43, I got diagnosed with antiphospholipid syndrome, which is called Hughes' syndrome. It's an autoimmune condition, but it causes problems with blood clotting and placental development. So women who have Hughes' syndrome often have recurrent miscarriage, but also it can be, complications in pregnancy as well. So I actually paid a lot of money of my own. I sold a house and funded private IVF and fertility treatment. And I had multiple cycles, and I actually got pregnant with twins when I was 43, and I became a mum when I was 44. The twins were premature, to be probably expected with the antiphospholipid syndrome. So yeah, I'm an much older mum, and all of that experience has fueled my interest in patient experience of fertility treatment, and then how we can use that in educating healthcare practitioners and doctors. One, on kind of nutrition and lifestyle medicine, because that's not in the mix in the UK. Also, on working together with other complementary therapies, actually, as well, and looking at the evidence for those, but then also on listening to patients and their view on treatment and what makes it better, what makes it worse, and things like communication. So that's the kind of thing I'm trying to work on now.
Mm-hmm. My goodness. Well, thank you for sharing your story I mean, it's just, you had an experience that's so profound. And one of the things about having a podcast and doing these interviews is that in the span of just a few short minutes, you took us through about a decade or so of your life and just so many things that happened during that time. And I mean, there's a couple of things. One of the questions I wanted to ask, because you said that it's like a really specific question, but you said that they had diagnosed you with this antiphospholipid syndrome.
Yeah.
And did they have something for you for that to help?
Yes. They actually prescribed aspirin and injectable blood thinners. So the brand name that I was given over here was Clexane in the UK. That is the recommended treatment. And actually, I do think that made it a difference, because obviously, I mean, it's amazing that I actually got pregnant with twins through my last IVF cycle, a real blessing. And, there's two little boys sitting upstairs waiting for me to go and sort of kiss them good night. So that, it's a real gift. But that's the first pregnancy I had when I received the appropriate medication for this antiphospholipid syndrome. And what the blood thinners and aspirin do is they keep the blood flowing so the placenta keeps functioning. It doesn't fail which is what must have happened in my, earlier pregnancies. But it's kind of a bit of having that and endometriosis, it's a bit of a double whammy. Having the endometriosis on its own can cause enough problems. So actually having the antiphospholipid syndrome as well, it sort of made it kind of extra hard, I think, to then maintain the pregnancy. And I think that, the biggest thing that happened to me is that with each loss, it was really difficult to then face getting pregnant again. And the anxiety that went with that over, am I going to keep it? Am I going to lose it? Every day thinking, is the baby still alive and inside? And actually in the twin pregnancy, I had the most awful bleeding up to 17 weeks of pregnancy. I actually had a subchorionic hematoma, which is where the placenta doesn't embed properly into the uterus and it bleeds. And all the time I was being told this is a pregnancy at risk. It's a high risk pregnancy because you're over 40. It's a twin pregnancy. You've got this antiphospholipid syndrome and you've got this hematoma. So the anxiety in that pregnancy was phenomenal, actually, and had quite a lasting impact on me. And I had to have quite a lot of therapy, actually. After I had the twins, I had some specialist kind of trauma therapy to kind of help me through that and to process it. And I think, somewhere kind of deep inside me is this sense that actually the work that I'm doing might help somebody else who's having similar difficulties. And actually that helps me, knowing that I might, or some of the work that we're putting out there, with the collaborator. I don't work on my own. I work with, collaborators. I write collaboratively. I supervise students like Joe, who was on the podcast. I didn't supervise him, but I supervise others doing research on infertility. So it's with them trying to make a difference that might just make a little bit of difference to somebody else's life in terms of either the care they get or the advice that they receive, I think. So, and that's transformational, really, for me. Mm-hmm. So it's a win on both sides, I think. Mm-hmm. And it motivates me to keep going with it. I keep at it.
Yes. Well, and I mean, one of the things that we had talked a little bit about in the pre-chat was, I feel like there's two kind of things that I wanted to bring out. One is how our culture addresses fertility, or rather doesn't address it. And so one of the things that my longtime listeners have heard me say many, many times, especially given that most women learn about how their cycles work and ovulation and cervical mucus and the things that you were talking about, most women learn that either when they're trying to get pregnant and it doesn't just happen, and then they have to kind of scramble to figure out what's really, like, how does this really work? Because I thought I would just be able to have sex and how to get pregnant. And then the other women who tend to find out about it are women who discover fertility we're in a cyclocharting for other reasons. And then other than that, we just don't know. So most of us are living our lives thinking that we can get pregnant any day, that it's a given, that it's easy, that it's just going to happen. And we live in a culture that really prioritizes everything other than motherhood. And so it's a really strong kind of afterthought, I think, in terms of the way our culture.
I think culturally, this sense that it's almost automatic that you will have a child, that it's never really taught that some people don't have children, and that, some people choose, well, it's not really childlessness, either voluntary childlessness or involuntary childlessness, and not really on the radar of teens or early 20-somethings, because people assume they can have a child if they want one. So actually, I think bringing that into education much earlier would make so much difference, but also talking to women about the best time to have children, biologically, about declining fertility with age and ovarian, the fact that they're actually born with all their eggs, and that as months and cycles go by, their fertility is declining. Because I didn't understand, age 37, I didn't understand that my fertility potential was reduced then. It came actually as a big shock to me, because I didn't realize that it declined so much age 35 and then, again, post 40. And I think that making people aware of that is going to make people's lives better, because they can plan better. Mm-hmm. I wouldn't, in a way, I wouldn't change a thing now about my journey, because I've got those two lovely boys upstairs, and, I'm so proud to be their mum. So, if I had succeeded in my earlier pregnancies, I wouldn't have them, and I can't imagine my life without them. So it's sort of, now I think I look back and I can accept it. But at the time that I was going through it, it was very hard to go through. And I think you get to this place of acceptance as well by doing something positive, don't you, for other people. So I think, fertility education, it's a big priority, and a missing link in education for people, both genders, men and women.
Mm-hmm. Well, and one last point that I wanted to bring out from your story as well was the whole diagnostic journey that you went through. And so correct me if I get any of the details or incorrect, but you were 37, were you having miscarriages up at that point, or just not conceiving at all at that point?
So I'd had two miscarriages already in my early 30s, and right. Age 37 couldn't conceive.
Oh, that's age right. 30, because you had the two miscarriages with your previous partner.
Yes. And then what happened is I was diagnosed with unexplained infertility, actually. But then I did get pregnant, and I did get pregnant naturally, but then I miscarried again. And then I had a chemical pregnancy from IVF, which it's an extremely early miscarriage. So I had another two miscarriages sort of after the age of 39. And then age 41, after having lots of blood tests, lots of STD screens, scans, one's on the tummy and then one's vaginally, where they're looking at my ovaries. I had my AMH done as well, being told your ovaries are fine, your uterus looks fine. And then eventually sort of chipping down the list of the procedures, getting to this place where they were talking about a laparoscopy, but saying I didn't really qualify because of my age to have it. So I paid for one privately, and so I went to see a private doctor, and that's when they told me I had endometriosis, and they ablated the endometriosis, and he did a pretty good job of that, actually, because it didn't grow back. I've had another laparoscopy since, but I think I had some adhesions from my C-section. It wasn't, I thought the endometriosis had come back, but it was adhesions, and they said the endometriosis had stayed off, which is really good. So at that point, then they find a reason. So the unexplained infertility, goes away.
Unexplained, yeah.
It's not unexplained. I often think that unexplained infertility means they haven't found the reason.
Well, I mean, that's, I had a Dr. Tom Cowan on my show years ago. Mm-hmm. And there's this part in the episode where he kind of compares infertility to, he's like, well, what if you couldn't have a bowel movement? Are the doctors going to be like, well, some people have bowel movements, some people don't. So, I mean, I'm not saying it's just that simple, but I think the point that he was making is that a healthy reproduction should be a normal thing for a healthy human being. So if it's not happening, we should be looking at it. But I brought up the kind of diagnostic story as well, because one of the topics that we had touched on in our pre-chat was just that for many women, so endometriosis is the perfect example, because the study you had mentioned taking an average of 8 years, I think there's one study that looks at the diagnosis timeframe in the UK and one that looks at it in the States, and it's something between 8 and 9 or 10, depending on where you are, maybe even 12. So it's just completely, I mean, that's a problem. And
we just had a government report on endometriosis in the UK at the back end of last year. And that said, in the UK, the average time is 8 years. And
that's average. That means there's some women that are getting it diagnosed after 12 years and other women maybe who get it sooner. But given the connection between endometriosis and infertility, and also in your case, having the recurrent miscarriages, I mean, obviously we can't go back, but for the listeners who maybe tuned into this episode because we're talking about fertility challenges and maybe have gone through some of these challenges themselves, unfortunately, as women, we have to really advocate for ourselves and kind of like, ram our request down the throats of like, you really have to push to get a diagnosis for something like endometriosis. And you really, really have to push to get someone to take you seriously if you're having like recurrent miscarriages and things like this.
I think we have, I remember going in my very early 20s to the doctors and saying, I'm having a lot of pain. I remember at one point being told I was constipated and not really.
That's why you were in all this pain during your period, or was there that pain outside of your period?
I had, to be honest, I usually had pain from ovulation to the beginning of my period. So for the last 2 weeks of my cycle is how my pain went. And that makes complete sense with endometriosis.
It's a huge flag.
huge flag. But sort of being told to go, being dismissed, feeling ashamed, feeling there's something wrong with me, that I can't bear this pain, living on paracetamol, hot water bottles. I think you realize that there's something really wrong when you feel like you can't go to work. if you've got such bad period pain that it's making you feel that you can't go to work. And there's obviously something that needs to be investigated, but I think there's this degree of cultural normalization of pain around the menstrual cycle and dismissing it that prevents women from talking to their doctor, asking for help, and pushing when they're not being given that help. And that definitely was a factor in my case. And the other thing is that, for some people, talking about periods is still embarrassing. It's still taboo. People don't do it within families. So some girls, women are unable to voice this to anybody. So I think we need much better education around it. I mean, in the UK, I think they're setting up sort of endometriosis management, like specialist centres now, because they've recognised it as a, really severe problem. I mean, it affects about 10% of all women.
Of how it takes like 50 years or whatever for them to realize it's a serious problem.
Yeah.
I feel like there was an article that came out and it was something like they had proven that, I forget what it is now. There was something about like they had proven that period pain is as painful as a heart attack or something. I came across this really interesting research that you might be interested in. I mean, it's nothing that profound, but I was looking up something and it was like a research article that was actually quantifying the pain or the pressure. It was the pressure. And so they were measuring, you may have of course seen this already, but they were measuring the pressure of uterine contractions during labor compared to period, like uterine contractions during like a normal period where a woman doesn't experience pain, compared to the pain, like the pressure when a woman has moderate to severe period pain. And so what they found was that labor, like a good normal labor contraction had, the measurement was in milligrams of mercury. And so I think it was like 80 to 100 milligrams of mercury during a good labor. And during a regular period, it was like 20 to 40, if I remember correctly. And then guess what it was for period pain?
I don't know, 100?
400.
400.
And the researchers, I was so angry that day. And then the researchers wrote, something to the effect of, I don't remember the exact words, something to the effect of, so when women who have bad period pain say it's worse than labor, they may be evidence to consider that, or something like that. Like, it was very dismissive, even though, like, by their own numbers, severe period pain, these women were experiencing 4 times the pressure of these contractions than the women in actual labor.
Oh, they probably would say that further studies are needed to corroborate their findings.
Right. But so my point of bringing that up, I think, is quite obvious. But for any woman who has had those types of experiences where you're experiencing pain and the doctor isn't taking you seriously, I love finding data like that to show, no, there's legitimate data to show that this is real. It's not in your head. It is just as painful as it feels. And unfortunately, if you're in that situation where you talk to your doctor and he laughs at you or tells you that it's impossible, periods can't be that painful, etc., then you just sometimes you got to find a next doctor. Exactly. Yeah. There's no point in continuing that conversation. But to switch gears a little bit, before we do that, I just want to thank you for being so open and candid with your story, because I feel like this is how, as women, we kind of organize and solve these problems, because the system doesn't do it for us. So I feel like by sharing these stories, it gives validity. So women who are listening say, oh my goodness, it's not just me, right? And that's how we kind of organize. But you've done a lot of work. I did a quick search. I Googled you. I Google scholars you. One of the areas that you have published quite a bit of research in is in the area of gluten sensitivity, celiac disease. And so I'm sure there's plenty of ways we could take this, but if you like, I would love to ask you to talk a little bit about that. It's kind of a bit of a jump, but one of the trends that I've seen is that women who have kind of moderate to severe gut issues often, not always, but often have some challenges in the area of fertility. So, I mean, maybe a good place to start would be, tell us what is celiac and what is the difference between that official condition and then the kind of non-celiac sensitivity, gluten sensitivity?
I'm sure that's a really good place to start. So the first thing I'll say is there is a connection between female reproductive health issues and gluten, essentially. And the connections, may not affect everybody. It may only be a percentage of women, but it's definitely there and it's evidenced in the literature. So celiac disease is an autoimmune condition. About a third of the population have the genetic propensity to develop celiac disease. They've got these certain alleles, basically. It's either DQ2 or DQ8 on the HLA bit of the human genome. It can develop, but it doesn't develop in everybody that has those alleles. So what we don't really understand is what makes it develop, and they're starting to look at things like, is it infection, is it microbiome, what triggers it, and there's evidence emerging on that. But when it does develop, what happens is when people with celiac disease eat gluten, there's sort of a reaction in the small intestine. We've got little villi that help us sort of make the last bits of digestive enzymes that break down our food, but also that it's across the villi and the microvilli, which is like a brush border where absorption happens. So they're really important for us to absorb nutrients from our food. What happens in celiac disease is you get certain cells actually produce antibodies in response to gluten, and that creates a whole inflammatory cascade at the level of the villi and microvilli, which damages them. So one of the main symptoms of celiac disease is you get malabsorption syndromes. We used to think that everybody who had celiac disease was thin and had a bloated belly. But actually what we know now is that's not true. People can actually be overweight or obese and still have celiac disease. But what you can see is absorption difficulties with micronutrients. So there may be low iron or anemia. There may be low bone mineral density. In very overt cases, they may be underweight and thin, and it can be picked up in children who are failing to grow properly, which is one of the reasons in infants why, growth is measured. So celiac disease affects about 1% of the population. It runs in families. If you've got a first-degree relative who has it, then really you ought to be tested to see if you have it. There's definite overlap with other autoimmune conditions, things like rheumatoid arthritis, autoimmune thyroid conditions, also diabetes type 1, because we now think of that as an autoimmune condition. It impacts on fertility in women and men, in both genders. So you can see kind of subfertility in people with celiac that may be related to malabsorption of nutrients, low nutrient stores, low iron, maybe low vitamin D, low folate, low B12. These are all key nutrients for cell replication and growth. So they can impact on the ability to, get pregnant and sustain a pregnancy. So celiac disease is known to also cause obstetric complications. So you can get low birth weight babies, premature delivery. Women can find it hard to breastfeed as well when they have celiac disease. So it's been documented. And
why on the breastfeeding front?
I think, again, it might be down to calories, nutrients, malabsorption. I don't really know other than that why, but it's associated with difficulties in breastfeeding. So I think that's been kind of established for a long time in literature. The thing that's interesting about celiac disease is we used to think it was extremely rare, and then suddenly it becomes one in 100 people. And actually, we think it's probably more, and quite often the diagnosis gets missed. So what can happen is in people with subfertility, people who can't get pregnant, they might never have been tested for celiac disease. And actually, it might be, if you looked at what's going on with them, it might be really obvious that, maybe their mum or dad has got celiac, and their whole fertility issue might be because they have celiac disease. So non-gluten sensitivity is controversial, and it's only really it was first reported in the literature in about 1980 by Dr. Jeffrey Holmes. And it's controversial because there's no diagnostic criteria. So celiac disease is diagnosed through a combination of blood tests where they look for the antibodies, but they do biopsies as well where they look for the damage on the villi and microvilli. In non-celiac gluten sensitivity, there is no diagnostic test, and that always makes for controversy. So it's a clinical diagnosis. They do it by ruling out celiac disease, by ruling out other digestive conditions. And then there's been a protocol suggested for removing gluten from the diet and then challenging you with a certain amount of gluten. And it should be done blinded, but often can't be done like that in hospital setting because they haven't got the resources. So it's controversial. And there's some studies saying it's not really the gluten in grains that's causing this non-celiac sensitivity, that it's other components of the grain, because there's lots of indigestible carbohydrates and things like that can also cause symptoms. There's lots of things in grains that can cause problems. But non-celiac gluten sensitivity, in my own clinical practice and research activity, I've seen it existing as a separate entity aside from these other issues, grain-based issues. So I believe I have evidence, and I've published evidence that it exists. So that in 2015, I published the first case report showing an association between that and reproductive problems in women, in particular recurrent miscarriage. And this is a case report that I published from my own clinical practice. And I'm really proud. And it is, in terms of the hierarchy of evidence, it's kind of quite low down because it's just a case report, but it's the first one. Mm-hmm. And that association with recurrent miscarriage and gluten in people who don't have celiac disease has now been reported in other literature. And they've acknowledged the 2015 paper that we published as the first one. So that means that for women who have, maybe I think the second paper that was published details a woman who might have had 9 miscarriages. And what they did is they just put her on a gluten-free diet, and she was then able to have a baby. So if you're talking about interventions for fertility, that is kind of quite low risk, minimal, not expensive, not invasive compared to undergoing IVF, ovarian stimulation, the risk of hyperstimulation syndrome, and all of those things. And then, compared to, other potential routes like surrogacy, because I know there, when women have had like 9 or multiple losses, they do start to consider things like surrogacy. So a gluten-free diet is kind of very easy as an intervention and probably worth a try in women with unexplained like recurrent miscarriage. So there aren't any double-blind, placebo-controlled, randomized controlled trials. One reason for the dearth of data like that is that it's really difficult to get ethical approval for studies on pregnant women. So, if anybody's trying to get pregnant, then usually ethics committees at universities will go, no, you can't do that study. So then that limits the strength of evidence, because all you've then got is the case-based data to be able to present from. So we need some brave funders really to look at whether these kind of things can be done as bigger clinical trials to get the weight of evidence up there and to see if it works. So there is an association, and endometriosis we've spoken about. Gluten sensitivity is really common, and celiac disease is. So there's a greater, if you've got endometriosis, you're at higher risk of having celiac disease. I think the data says it's around 4%, not 1%. So quite a large proportion, more than normal amounts, more than the healthy population have celiac, but then also they may have a gluten sensitivity if they haven't got celiac. So it links into these other conditions. And a gluten-free, there is data. I have seen a trial that was done in Italy actually on endometriosis pain and using a gluten-free diet as therapy for that, and it lessening pain scores. So we don't really understand the mechanisms. In non-celiac gluten sensitivity, it seems to cause systemic inflammation through the body. You don't get that autoimmune reaction at the level of the villi, but it seems to be causing an inflammatory response through the whole body, and that is maybe linked to the symptoms and the fertility problems. There may also be malabsorption as well. So, it's really interesting. So I started to get interested in gluten before I was interested in infertility, but then it became apparent to me that there is this relationship, and I am really interested in how that they work together, and trying to get fertility doctors to be aware of celiac disease and to maybe just consider doing a celiac blood test. It's very cheap, and to run that maybe as part of their initial diagnostics, it could help some people. So obviously I've worked on some textbooks and things where we're trying to sort of talk about that and present case studies and some of the evidence that is out there.
Just popping into today's episode to tell you a little bit about the show sponsor, Saturate. One of my top recommendations for women coming off birth control, looking to balance hormones or preparing for pregnancy, is finding a way to incorporate liver regularly into the diet. So why liver? Well, liver is one of the most nutrient-dense foods available. It's rich in folate, choline, vitamin B12, iron, vitamin A, selenium, zinc, coenzyme Q10, and I could go on, but I'll stop. But unless you grew up eating it, many of my clients have a hard time loving the taste. And that's where Saturate comes in. Saturate A+ liver capsules contain 100% Australian grass-fed and finished beef liver, freeze-dried and 100% pure, so no fillers, no preservatives, or any of that other junk. Head over to fertilityfriday.com/liver today and enter coupon code FertilityFriday for a 5% discount off your order. That's fertilityfriday.com/liver. Now let's jump back into today's episode. Well, I wanted to ask a practical question about symptomology, because I'm curious how you describe some of the celiac common symptoms essentially being the malnourishment and potentially, not always, potentially being underweight because of that malabsorption. But could you share with us some of the other symptoms? I mean, I'm certainly an expert in celiac. My understanding is it's very severe for a lot of people.
It can be. I mean, people with celiac disease may have anemia, and they may also have low B12 or low folate.
Well, when I say severe, I've just worked with some women who have certain issues where they can see, like if they get any gluten in there, they just have such a really significant physical response to it. So, but you mentioned that some individuals can have it and not know or have it not diagnosed.
Yeah. So, there is a condition called latent celiac disease or silent celiac disease, where people have the symptoms. Well, they have the antibodies, but no symptoms. And there's kind of a few hypotheses about why this might be. And one of them is that when gluten crosses the gut lining to be absorbed, it actually has a structure which is similar to an opiate. So there is a school of thought, and there's some papers published on this, that actually that is masking symptoms. So some people can be asymptomatic, and they may also have constipation. And one of the side effects of opiates can be, of codeine, for example, which is an opiate, can be constipation. So not everybody is symptomatic. So in silent celiac disease or latent celiac disease, they've got the antibody response, but no obvious symptoms. In non-celiac gluten sensitivity, the symptoms are it can affect the whole body. So it can impact on mental health, mood, it seems, energy levels, as well as skin condition, itchiness, as well as the tummy and bloating and indigestion and abdominal pain and wind, all these things. So you can have symptoms that are in the gut and symptoms that are outside of the gut, sort of kind of systemic, and quite, anxiety, sleep have all been mentioned. There's also been cases of gluten-induced psychosis documented in the literature as well. So, quite far out symptoms.
Well, a couple of years ago, I invited Dr. William Davis, the author of Wheat Belly. Are you familiar with him?
Yes, I am.
So for any of the listeners, I mean, it's a very, first of all, if you read his book or watch his talk or listen to the podcast, I'll link the podcast in the show note page. I don't remember exactly what number it is, but it's the kind of episode where you listen to, and if you happen to be holding a baguette, you're going to throw it out the window because you're so scared by the end of it. So honestly, I've heard kind of the gamut. And there certainly is an argument to be made about gluten as a concept not being the best thing for people, certain people more than others.
Yeah, I think gluten is fine for some people.
Yes.
I think the trick is to identify if you're one of the people that can't eat it. It's been in the human diet for around 10,000 years. It definitely helped us survive, periods of famine.
Well, see, that's where Dr. William Davis, that's where it gets interesting, because his argument is that modern wheat is not the same, right? Yes, so it's a whole thing.
It's true.
And it is true, because it's not the same. He makes a very compelling argument. Gliadin. Oh my goodness.
Yeah. And also we now grow wheat with large amounts of herbicide.
Well, that was going to be my second comment, because a couple of years ago, I think I did a two-part. I think it might've been one after the other, which would have been a very difficult couple of weeks, where I interviewed Dr. Stephanie Seneff, who specializes in glyphosate.
Yeah.
And we talked about glyphosate. And so it's complicated, but what I'll just quickly, what I've found when I'm working with women is it's what you said. Some women are affected by it. Some women aren't. And now you've listed a third category of some individuals are affected by it, but they wouldn't necessarily know. Yeah. And for those who are affected by it, it causes big problems for them.
Yeah. I agree. And the glyphosate issue, I really hope we see clarity in the research on that in the next kind of few years. I've just written a book chapter, actually. It's being published on the 17th of September. And it's all about gluten and gluten grains and all the different things in grains, all the different mechanisms and how they can impact on health. And, there's things that we haven't mentioned, like there's lectins, wheat germ agglutinin. And then there's also amylase trypsin inhibitors. These are kind of anti-nutrients that are in grains that are really resistant to digestion, and they might contribute to inflammation as well. So there's other things. There's FODMAPs, these indigestible carbohydrates as well. So there's lots of different potential mechanisms. When I looked at the glyphosate, it seems like the evidence is really clear for fish, and but not necessarily. We don't have causation data for humans yet. But what we know in animals is it has really profound effects on the gut and the microbiome. And the damage that you see in the animal studies mimics celiac disease. So it's really...
And that's from glyphosate, not...
Yeah. That's from the herbicide, yeah. So it's interesting, it's sort of one of the things, because I'm obviously a nutritional therapist where we look at using food as therapy. I'm really interested in what can you do to grain. So, I've eaten gluten-free for a number of years. I now eat gluten. It doesn't agree with me massively, but I really like the odd piece of toast, and it's really nice to be able to go out to eat with my children and not have to be on an excluded diet. So the impact of being on an excluded diet for a long time, it can alienate you from friends. It can make going out quite difficult. It can affect mood. So as a therapist, I want people to be able to eat a variety of foods. And there's certain cooking methods and food preparation methods that make grains more digestible. So, sourdough fermentation, slow made fermented bread, using sourdough cultures. There's evidence that reduces the amount of gluten in grains. So, there's a role for maybe a small amount of that in the diet. If somebody is slightly gluten intolerant, but not celiac, can they actually tolerate a bit of gluten, bit of gluten containing bread, but made by sourdough processes? And there's also soaking of grains can reduce some of the amylase trypsin inhibitors, the boiling as well, sprouting. All of these methods can be really useful to actually make it more digestible, essentially. But I think, if you're struggling with infertility, conception difficulties, miscarriage, endometriosis, an autoimmune condition, skin problems, even mental health, sometimes it's just worth try for 2 weeks to take gluten out and see what effect it has on you, because it may have a profound effect. If it does have a profound effect, test yourself, have 3 days back on gluten, see what happens. Try and do this with input and guidance from a physician or somebody who's qualified in nutrition, a nutritional therapist. I don't know what you have in Canada that's similar, or dietitian, somebody that's nutritionally trained that can help you. And if you're going to have a gluten-free diet, you need to have a really well planned, it needs to be a balanced, well-planned diet that doesn't have a lot of the processed gluten-free foods in, because we know they're high in salt and sugar. So you need to have gluten-free whole grains. So it's including grains that are gluten-free and enough protein, so it's a well-balanced diet. And I think if you can do that and it helps you feel better, then that there's that maybe you're one of the people that shouldn't be eating gluten. But it is around, I think, testing yourself. And if you've got a parent or a grandparent who's got celiac disease and you've never been tested, then maybe you get yourself tested. I have published on gluten and mental health as well. Mm-hmm. We did a systematic review and meta-analysis on gluten and mood disorders. And we actually
that whole thing about the opioid,
it made a positive association. It's really interesting.
Well, yeah, it's and this is why listening to Dr. William Davis is it's just crazy, because if I remember correctly, it's been a while, but I think he's a medical doctor, and he just for whatever reason started to have his patients take out gluten. I'm sure there was a reason. I'd have to personally also re-listen to the episode. And some of the things that he found that are connected. One of the things that I remember is he said that when his patients cut out gluten, they would eat about 400 less calories a day.
It's craving. So that opiate kind of mechanism can stimulate cravings as well. I think malnutrition also stimulates, when you're malnourished in certain nutrients as well, your body's kind of in a way trying to correct that malnutrition. So I think that can stimulate cravings. But also just that blood sugar, if you're eating a lot of refined carbohydrate in bread form, that can spike your blood sugar, then it dips and you eat more. So if you take that out of the diet and you've got more stable blood sugar, then you can usually find that calorie intake reduces. So, I think lifestyle medicine, nutritional medicine has a lot to offer. And in fertility treatment, it's not embedded. It's not embedded in in the UK. It's not embedded in care. In a few private clinics now, we're seeing it embedded with complementary therapies like acupuncture as well. But it's, the minority. And in the majority of care options, it's not considered, it's not looked at. And, the only thing that really is looked at is weight. It's smoking, weight, your BMI particularly, and alcohol intake. And there would be advice given upfront about that, but they wouldn't really consider anything deeper beyond that, or think about micronutrients. I mean, even things like vitamin D, that's key as well. So yeah, I think it gets overlooked and has a lot to offer. And I'm looking at publishing bits of research on patient experience where we learn from patients, but also using patient experience about this, what has changing your diet or lifestyle enabled you to do in kind of medical education and healthcare professional education. And then also trying to give in academic textbooks for doctors, trying to give them the evidence on what can happen if somebody eats oily fish and some legumes and some quality, fruits and vegetables, 5 or 6 or 7 portions a day.
It's so ironic that the doctors are where we primarily go for care. And unfortunately, they have just very little, if any, standard education around nutrition. And as you were talking about these things, you mentioned that for non-celiac gluten sensitivity, a person can have this gluten and then it can cause essentially a full body inflammatory response, or it could be anywhere in the body. And so it's kind of like anything that can cause a full body inflammatory response is obviously not good. And so from the cycle charting perspective, those are the kinds of things that cause cycle issues and hormone issues as well.
Yeah.
And so the question, I suppose, out of that, one of the things that I was thinking about is for celiac. And so just give us a general sense for someone who's listening and who's now convinced, right? That's how it works. They're convinced they have celiac or wondered if they could possibly have some sensitivity to gluten or those types of things. I'm curious about then the treatment strategy. So is it primarily to then remove gluten, or are there other treatments that can be alongside to reduce the inflammation or further kind of support them on this process?
Yeah, so I think if somebody thinks they have celiac, and if they've got a family history of celiac disease, they really need to go and see a doctor. They need to get the serological test. So that's where they screen for antibodies. There's different antibodies that they test for, but you go and get the blood test. And then if there's certain clinical indicators, they may send you for an endoscopy, and a biopsy would be taken of the small intestine. So I think it's really important that that's physician diagnosed. Celiac needs to be medically managed. The treatment for celiac disease is a lifelong gluten-free diet.
Is that, I guess I wasn't asking for anyone to skip that, because of course it's a serious condition and proper, but when that diagnosis is, so other, of course that's the big part of it.
So they might give them iron. They don't tend to give anti-inflammatories. I mean, I think that from a natural medicine point of view, nutritional medicine point of view, I would be wanting to get the gut membrane healed. You're thinking about like quality proteins, maybe bone broths, all those kind of things to get the gut membrane healed. And then you're thinking about a bacterial balance, probiotics to keep the gut healthy. But I wouldn't do that until, the membrane's healed, because you don't want them crossing into the bloodstream. So, but that isn't generally medical treatment. So If there was anemia, then that would probably be medically managed with iron supplementation. If there's low B12, then obviously that's sometimes medically managed with injections as well. So I think, if there's other autoimmune conditions, because you do see the overlap with celiac, then obviously they would be medically managed. Non-celiac gluten sensitivity, again, so with celiac disease, it's a strict gluten-free diet and it's lifelong. And usually that will result in the restoration of the gut, the healing of the gut. There is a rare type of celiac disease called refractory celiac disease where that doesn't happen. Once you've been exposed to gluten, the gut stays damaged, it doesn't heal. And that unfortunately has a really poor prognosis with high mortality. Moving on to non-celiac gluten sensitivity, the treatment there is really, again, around addressing if there is any nutritional deficiency. Does somebody have low vitamin D or B12? Are they anemic? If they're not, then it's healthy, balanced diet. And I would try a gluten-free diet. But it may be that, after kind of maybe a few months gluten-free, it's worth experimenting around to try and establish whether there's a level of gluten tolerance. And this would be around using products that are maybe like the sourdoughs that lessen gluten content, because I think that can impact positively on quality of life and the ability to socialize. So I think with non-celiac gluten sensitivity, I would say complete removal of gluten for kind of 2 or 3 months with challenges so that it is a factor. But then if you can address the gut lining and support its healing, you might be able to reintroduce tiny bits of gluten maybe once every 3 days. And that might mean that you can go out for dinner. And that might be really positive for you mentally. So I think that it's around experimenting to establish if gluten tolerance is possible. And you might need to do that with a nutritional professional. But that would be my advice there. I mean, it's not so dangerous to have the odd slip up. I mean, yes, you might be feeding into other symptoms by kicking off the kind of systemic inflammation, but it's not really, once in a while it's going to happen because, some gluten-free foods are even contaminated with gluten because of the way that flour is milled and things like that. So it's small amounts of gluten are in the food chain, basically, even in gluten-free products. So I think it's not life-threateningly dangerous if you have non-celiac gluten sensitivity for a slip-up. Yes, it may make you feel uncomfortable. It may affect tummies. But if the food is treated in the right way or cooked in the right way, you might find you can tolerate a tiny amount. And that might be positive to add in. So,
well, the reason that I had asked the question about the kind of medical management and how that is organized, because if a person has had struggles with celiac and then they're finally diagnosed and then they're basically prescribed a gluten-free diet, if they're not necessarily aware of a more functional approach to this and the other additional things that can be done, they might feel that, okay, that's it and that's all I can do. And then that's really what they're doing. And so they're trying to avoid gluten. But if you were coming from a more functional approach, I feel like there would be more to this story because my understanding is that celiac, when you're exposed to gluten for many individuals who have celiac, it causes destruction of the gut. Like this is why it's such a serious condition. So it's severe. And so if there's not a standard of care that involves the systematic healing and kind of acknowledgement of that aspect of it, I just have personally wondered about whether or not that is best for, to leave them with just that. Because it's important to avoid it, but there should also be some, I feel like, and then what happens when they're exposed? Because what you said as well, people who are celiac obviously know and do everything they can to avoid, but it doesn't mean that they never get inadvertently exposed to gluten.
Yeah. And some, there's quite a lot of data around teens that are celiac not sticking to their gluten-free diet. So there's certain kind of phases in life where people might digress from it. So compliance to the diet may not be 100%. I mean, I think in the UK, the treatment is a lifelong gluten-free diet with monitoring of nutritional deficiencies and treatment of those. So that would primarily be B12, folate, iron, vitamin D that they would look at. And they may, if there's osteopenia, which is low bone mineral density, or osteoporosis, then they would be managed as well. Anemia would be managed, vitamin B12 through injections. They don't use a functional approach in our socialized medicine in the UK. I think it is missing. I think it can encourage, probably, if you can get health restored internally in the gut and bacterial balance and gut membrane working well, I'm sure somebody would get back into optimum health much more quickly. And in non-celiac gluten sensitivity, I mean, that is still probably quite difficult to get diagnosed in our system of socialized medicine in the UK. If you're lucky, it might be diagnosed, and the recommendation, it's going to be similar: gluten-free diet and then management of nutritional deficiencies. So I think they're not really necessarily looking at optimizing what we know from a functional medicine point of view might make a difference. So that is sadly still outside of our healthcare system in the UK. It exists in private practice for people who have money and can pay for it. What I'm trying to do is try to get that thinking into some medical texts. So we're trying to get
we're thankful for you to
message out
to do this.
Just in tiny little areas like infertility, women's health, mental health.
Yes.
Trying to get that message out to people that are training so that there is more awareness. And I think that the more is done, hopefully we'll get that, maybe in 10 years. I think changing practice is a massive challenge, isn't it? A changing practice across the globe, it's
Well, don't
huge.
They say that it takes an average of 20 years before new research is incorporated into medical practice?
Yeah. So changing practice is a massive challenge.
Yes. Well, as we wrap up, this conversation that we've had, I feel, has been just incredibly informative. And I just really appreciate you taking us through celiac and gluten. I feel like it gives a lot to think about. And I feel that your approach is obviously balanced and realistic to say that for those for whom it impacts, it's something that you should really seriously look at. But obviously, everybody does not have this specific issue. But for those who do, it's quite serious. So with that in mind, and considering everything that we talked about today, what kind of, if you could leave the listeners with one message or a couple, what would you want them to know?
I'd want them to know that the way that you kind of live and eat impacts on your whole being. And actually, if you can really enjoy your food, think about nourishment, nourishing your body, listening to your body in a way as well, in terms of maybe what you want to eat and thinking about why you want to eat it, that in a way you're kind of honoring your body. I think don't be afraid to ask for help. Don't be afraid to go to the doctors more than once. Don't be afraid to talk about pain if it's really bad, and try to some degree, try to take responsibility for your own health. If you think that the way you are eating is impacting on your health, go to see a nutritional therapist, nutritionist, dietitian. See whether with a few tiny tweaks you can make any difference in the way that you feel and your symptomology. If you do have period pains or irregular cycles, or you're struggling with weight loss or hormonal imbalance or premenstrual syndrome, see if you can get any shift in symptoms with simple dietary tweaks. So I would say just try to think about the connections between food and your body.
I think those are important words to end on. Thank you so much for being here today, Justine. This has been just such a treat and so informative, and I'm really excited to share this episode. I've worked with a number of clients over the years who have a variety of different issues with gut health, whether it's something along the IBS spectrum or Crohn's or celiac or something more specific. And certainly this episode, I'm sure, as a side note, I'll also say that many of my clients who do struggle with these challenges, or SIBO as well, so issues with gut health, for many of them, it's kind of one of the most challenging issues to have, challenging to get an accurate diagnosis, and challenging to get successful treatment. I've had many clients go through several rounds of different kinds of treatment with different practitioners, and sometimes it works and sometimes it's not as effective. So the whole just realm of gut health and fertility is it's so important that we're getting this information. So thank you again.
Yeah, so thank you for inviting me, Lisa. It's been great to talk to you.
Well, and so for the listeners who want to learn more about you, I will be linking some of the papers that we talked about, including the 2015 paper in the show notes page. But where can the listeners go if they want to learn more about you and what you do?
So I have 2 profiles on 2 UK universities because I work in 2 universities. So I have a profile, if you Google me, on the University of Worcester staff pages. And I've got my full publications list there with some links to the publications that are open access. And I also work at Cardiff University Medical School, that's in Wales in the UK. It's quite a prestigious medical school, and I work there in the Centre for Medical Education. I have a profile on that page with a few links to the research that I do as well.
Great. Well, I will add those and make sure to link for those who want to follow up with you. And thank you again for being on the show.
Okay, thank you, Lisa. Bye.
Thank you for listening. If you enjoyed today's show, please share it with a friend. You'll find the show notes page for today's episode over at fertilityfriday.com/386. I hope that you enjoyed today's episode with Justine. I mean, what an incredible story. I'm just so honored that she felt comfortable enough to share her personal story and experience with fertility challenges. Of course, just what an incredible story that she was able to conceive when she was in her 40s, twins nonetheless, but the challenges that she had to go through in terms of having her endometriosis diagnosed, as well as the clotting disorder that she talked about. It really does speak to how difficult it is for so many of us women to be taken seriously by the healthcare system, to receive adequate care, to receive accurate diagnosis. And Justine's experience of having a long delay to having her endometriosis diagnosed is very much in line with what the research tells us, and also what the experience of many women are. And so this is why I always talk about period pain, because so many of us have been conditioned and told that it's just normal, it's just a part of being a woman, we don't necessarily have anyone making those connections for us, especially at a young age, that it could potentially be a sign of a deeper problem that could potentially affect our fertility later on in life. And so I think one of the most important aspects of the work that I do is spreading awareness and giving a place to share that information, with the hope that young women who are hearing this, and women of all ages, of course, may be empowered and may have different options than maybe I did, or than maybe Justine did. Because what a difference it could make if we actually learned about these things early and were able to get those diagnoses if we need them early, if we were able to get the adequate care that we need. And if we're not learning for the first time about how our cycles and our fertility works, in our 40s. So we all kind of do the best we can with what we know, of course. And so if you're listening to this and have recently discovered fertility awareness and you're, in your late 30s and 40s, you're not alone. I get messages every day. It's a very common experience. But of course, I still hold out the hope that for younger generations, it might be different for them. So with that said, I hope you have a wonderful weekend, whenever you're tuning into the show. And of course, as always, until next time, be well and happy charting.